Hi everyone, this is Nurse Anna from nursestudy.net, and we're going to be doing our first case study bow tie method. This is our first one in the series, and we're just going to kind of see how it goes. So the bow tie method, it does look like a bow tie. So basically these are the wells here, and I tried to make everything match and color coordinate. So we have, we're going to have a question, we're going to have a scenario, and then we're going to try to choose the condition most likely that the patient is experiencing, which actions to take, and what parameters to monitor. So our scenario is a 68-year-old client presents to the emergency room with complaints of black tarry stools for the past 24 hours, fatigue, dizziness when standing, and the patient takes daily aspirin and was recently prescribed ibuprofen for arthritis pain. Our vital signs are blood pressure of 92/58, heart rate of 112, respiration rate of 20, and O2 sat at 94% on room air. So again, we're going to be looking at this scenario with what we just read, and we're going to go ahead and try to match all these boxes. So potential conditions, we're going to start here. We're going to start in the middle of the bow tie. So our choices are upper gastrointestinal bleed, peptic ulcer disease, Mallory-Weiss tear, diverticulitis, or esophageal varices. So again, if we look at the scenario, I'm going to go ahead and I've highlighted what stood out to me. So 68-year-old male in the ER with complaints of black tarry stools, that's significant. Fatigue, dizziness when standing, daily aspirin, ibuprofen, and the vital signs. I should have highlighted 92/58, that's hypotensive, and a heart rate of 112, tachycardic, and a 68-year-old male with a 94% on room air. I would probably highlight that too. So the first one is diverticulitis. I'm going to rule out diverticulitis because this usually presents with low GI symptoms and abdominal pain. We didn't have any of that in our scenario. Peptic ulcer disease I'm going to rule out because this may be the cause, but it's not an immediate concern. The immediate concern is the active bleeding. Mallory-Weiss tear. Well, this usually presents with bloody vomiting after, forceful vomiting. Esophageal varices. This is a big one you'll see in the ER a lot, but there's no mention of liver or disease history. So this is the one that's left. Upper GI bleed, I'm going to turn green, and the reason is we have the presence of black tarry stools, which means digested blood from the upper GI tract, hypotension, and tachycardia. Remember, that's what we highlighted in our scenario. He was hypotensive, and I believe his heart rate was like 112, which suggests significant blood loss. Risk factors that are present, well, he's on NSAID, so we have aspirin and Motrin use. And then signs of hemodynamic compromise. He was dizzy and tired. So upper GI bleed seems to be the best one for us. And I want to take a little break here and say, please go to nursestudy.net. I have, I believe, over 1,000 articles now. This one is for GI bleed, and basically it'll give you like a brief synopsis of what a GI bleed is, nursing diagnosis, and care plans. And this is a free website. So you just go there, search what you're looking for, and then it'll give you the nursing diagnosis and care plans for that particular subject. Okay, so we have chosen the upper GI bleed. Okay, so I have put upper GI bleed up here in potential conditions. And now what we're going to do is, again, where I've unhid the actions to take and parameters to monitor. Like next we're going to go to actions to take. Establish a large bore IV, 18 gauge or higher. Basically, depending on the ER, they'll say 20 or larger, but really 18 gauge or larger is the best. And that's essential for rapid fluid resuscitation. Remember, this person is hypotensive and tachycardic, dizzy, fatigued. Allows for quick blood product administration if needed. and it's critical for hemodynamic stabilization. I mean, we're going to start giving fluids, and that's right here. Next, so we'll make that one green, pretty good one. Obtain a type and cross match for blood products. Well, sure, they'll probably have a low H&H. However, we have to stabilize this patient. So while it's essential, this can be done after establishing IV access. Blood samples can be drawn when placing the IV line. It's not uncommon to go ahead and do a type and cross match and get all your labs while you're starting an IV. It's not an immediate priority compared to establishing access for potential transfusion. Position client supine if legs elevated. I think what the question's trying to say here is a Trendelenburg. And okay, sure, but however, this position can help with the hypotension, but this can be done simultaneously after establishing IV access. IV access is the most important. IV access and one other thing here. Cannot be the first priority as it doesn't address the need for volume replacement. This alone will not stabilize a bleeding patient. Remember, this patient is hypotensive, tachycardic, and is basically unstable. Monitor the vital signs every 15 minutes. Absolutely. This will enable early detection of deterioration, helps evaluate response to other interventions, and critical for monitoring hemodynamic status. Absolutely, here. Yes. Administer IV proton pump inhibitor. Well, sure, this could become an order later, but medication administration is important, but secondary to establishing access. You cannot give IV medications without first establishing IV access. Exactly. Treats the underlying cause, but doesn't address immediate volume loss. It requires physician order first. Absolutely. You can't give these meds without the doctor ordering it. Inserted nasogastric tube is ordered. While it's important for assessing upper GI bleeding and gastric lavage, this is a secondary intervention after stabilizing the hemodynamics. This could potentially delay more critical interventions. This requires, again, a physician order and should not delay IV access. We have our two here, but I just want to explain why the other ones are not immediate actions. Withhold oral medications. Sure, but this is a supportive measure. This is not an immediate priority in an actively bleeding patient. Doesn't address the need, doesn't address the immediate threat to life. Document stool characteristic. Okay, of course, however, this is not going to stabilize your patient in the short term here. So, important for diagnosing assessment, but not a priority intervention. Documentation can be done after addressing immediate patient needs, and it will not directly impact patient stability. Okay, so now looking at our updated chart, we have now put established large bore IV access, 18 gauge or higher, and monitor vital signs every 15 minutes. Those were the best. So now we're going to move to parameters to monitor. And we have hemoglobin, H&H levels, vital signs, especially the BP and heart rate, stool colors, the characteristics. These are things to monitor. Mental status, skin color and temperature, urine output, coagulation profile, and abdominal assessment findings. So let's go ahead and go through these one by one. Okay, so the H&H levels. Sure, this will tell us where we are with the blood loss and guides transfusion decisions and helps to track the response to treatment. Absolutely, this will be one of the right answers. Vital signs, especially blood pressure and heart rate. Exactly, this patient was hypotensive and tachycardic. So the blood pressure and heart rate changes that will indicate hemodynamic status. These are early warning signs of shock and are very important. This will also measure the response to the fluid resuscitation. Absolutely. 2 greens there. Stool color and characteristics. Okay, of course we want to monitor it, but again, we need to essentially save this patient's life. This patient is hypotensive, tachycardic, dizzy, fatigued. This can happen while you're doing other things. These two are the most important. So while important for an ongoing assessment, changes may not be immediate or frequent enough to detect rapid deterioration. Less reliable than the H&H or hemoglobin hematocrit for quantifying blood loss. More useful for tracking improvement than detecting acute changes. Mental status. It's important, but a late indicator of deterioration. Sorry, this is why the test questions have another voice to it. Changes typically occur after significant blood loss, less sensitive than vital signs for early detection of problems. And it's more useful as a secondary assessment parameter. Skin color and temperature. It's really a non-specific finding that can be affected by many factors. Changes may be subtle and subject to interpretation, less reliable than objective vital signs, can be affected by environmental factors or medications. So these three are a no. Urine output. While decreased output indicates poor perfusion, this takes too long to assess. These are typically measured hourly and may not reflect acute changes quickly enough. This is more useful in long-term monitoring. Coagulation profile. So it's important but not an immediate indicator of bleeding severity. Results take time to obtain from the lab, more useful for identifying underlying causes, doesn't help with immediate clinical decision making. Abdominal assessment findings. Okay, of course, we have a patient that's becoming unstable, so this is going to be one of like a secondary thing to do. So subjective, it may not change significantly with bleeding, more useful for identifying complication, less reliable than objective measurements, better for identifying cause than monitoring severity. So here we go with our bow tie, and now it's completely filled in. So you can see how we went through each and every one of these and we're able to figure it out. So here it is all filled out, and this is how it would look on the NCLEX NGN. And what's important is you just keep doing these and remember the ABCs, airway, breathing, circulation, especially when you have an unstable patient. So if you like these types of videos, I will be doing more, but please visit Nurse Study Net for free nursing diagnosis and care plans. And I hope you have a really good day.